As per the request, here's the descriptive video covering the ins and outs of ECG. The initial recording of heart's electrical activity occurred in 1972 by attaching wires to the patient wrist. And this picture is from 1901 showing the first ECG device ever created. The ECG is a diagnostic tool that captures the heart's electrical activity. The heart's conduction system, consisting of specialized cells, generates and transmits electrical signals to coordinate the heartbeat. A 12-lead ECG records the electrical activity of heart from different leads. The placement involves attaching electrodes to specific location on the body to capture electrical signals from different angles. Normal 12-lead ECG is taken by 4 limb electrodes and 6 chest electrodes, and each lead gives a slight different view of the heart. Lead 1 AVL V5 V6 look at the lateral part of the heart. Lead 2 3 AVF shows the inferior part of the heart. Lead V4 to V5 give a septum and anterior view. ECG has large and small boxes. The horizontal axis of large box is 0.2 second. The vertical part is 0.5 millivolts. For a small box, the horizontal plane is 0.04 second and the vertical is 0.1 millivolt. In order to understand ECG, it is important to understand the conduction system of heart, which begins from sinoatrial node, which is a pacemaker, which fires signal to atrioventricular node, then bundle of his right and left bundle branches, Purkinje fibers, so that heart can contract. When there is a stimulus, it is called depolarization, and when there is relaxation, it is called repolarization. And we can see all this in the form of waveforms. ECG captures heart activity in the form of waveforms, P waves, T waves, and QRS complexes. P waves represent atrial depolarization, which is the contraction of atrium, indicating the electrical activity as it spreads through the atria. The duration of P wave is 0.12 seconds or 3 small boxes. QRS complex depicts ventricular depolarization or contraction, reflecting the electrical signals as it moves through the ventricles. QRS complex can be less than 0.12 second or less than 3 small boxes. T wave represents ventricular repolarization or ventricular relaxation, showing the recovery of ventricles as they prepare for the next contraction. The duration of T wave is 0.1 to 0.2 seconds or 3 to 5 small boxes. We cannot see atrial repolarization because it is hidden somewhere where the QRS complex is. In between waveform, we have intervals and segments. PR interval extends from the beginning of P wave to the beginning of QRS complex, representing the time it takes for the electrical impulse to travel from atria to ventricles. Normal PR interval is 0.12 to 0.22 seconds or less than 5 small squares. QT interval starts at the beginning of QRS complex and ends at the end of T wave, representing the total time for ventricular depolarization and repolarization. The duration is 0.33 to 0.44 seconds or 8 to 11 small boxes. ST segment is a portion of ECG between the end of S wave and the beginning of T wave. It represents the interval between ventricular depolarization and repolarization, and the duration is 0.20 to 0.40 seconds or 5 to 10 small boxes. Abnormal P wave on ECG can be caused by conditions such as atrial enlargement, atrial fibrillation, flutter, atrial tachycardia, atrioventricular block. Right atrial enlargement can show P wave which display higher amplitude in lead 2 and lead V1. Such as P wave is called P pulmonale because pulmonary disease is the most common cause. Left atrial enlargement. The most striking sign of left atrial enlargement is a white P wave greater than 0.12 second or three small squares with a predominance of the negative final component in lead V1. There are different causes for abnormal QRS complexes such as hyperkalemia, where we can see white QRS complexes. In ventricular tachycardia, we can see white QRS complexes. Atrial fibrillation can show narrow QRS complexes. In ventricular hypertrophy, QRS complexes are very tall. In Wolff Parkinson's White syndrome, there is a delta wave, and in bundle branch block, we can see a deep S wave, notched R waves, and some pattern of RSR in V1, especially in right bundle branch block. Abnormal T waves can be seen in different conditions such as hyperkalemia. There is peak T wave. In myocardial infarction, initially there is hyperacute T wave without ST segment elevation. In transmural ischemia, there is high broad base T wave in conjunction with ST segment elevation. In post-ischemic state, there is inverted T wave. In hypertrophic cardiomyopathy, there is deep T wave inversion. And in pericarditis, especially in the later stages, there is also T wave inversion. Abnormal ST segments can be appreciated in different conditions, such as in pericarditis, there is diffuse ST segment elevation and PR depression. In myocardial infarction, there is ST segment elevation. In hypokalemia, there is ST segment depression. And in myocarditis, there is ST segment elevation. Abnormal PR intervals can be seen in different conditions, such as myocardial ischemia infarction, myocarditis pericarditis, Lyme disease, rheumatic fever, hypothyroidism, electrolyte imbalance, and particularly in atrioventricular block. In first degree atrioventricular block, electrical impulses conduct from atria to ventricle through atrioventricular node more slowly than normal, leading to prolonged PR interval. In second degree atrioventricular block, the impulse from the sinoatrial node is delayed, which results in a progressive PR widening pattern. In second degree atrioventricular block Mobus 2, there is a blockage at bundle of His. There is prolonged PR interval, but this prolongation is constant throughout the leads. In third degree atrioventricular block, there is a complete block, no P wave produced QRS complexes. So there are variable pattern of PR intervals. An abnormal QT interval on ECG may result from different factors, including long QT syndrome, where we can see a prolongation of QT interval. We can see hypocalcemia, where we can see prolonged QT interval. In hypercalcemia, we can see short QT interval. In hypokalemia, there is prolonged QT interval. Normal rate is 50 to 100 beats per minute. The rate can be counted by square counting method, which is by counting the number of big boxes between the R waves using the following sequence of number. If there is one box, it is 300 beats per minute. Two boxes, 150 beats per minute. Three boxes, 100. Four boxes, 75. Five boxes, 60. Six boxes, 50 beats per minute. If the rhythm is irregular, then there is a formula, which is 6 into number of RR intervals in 10 seconds, because a standard ECG is 10 seconds. So when we count the number of RR intervals in 1 10-second strips, we can multiply it with 6 and we can get the rate for irregular rhythm. Here are a few examples. The first one is sinus bradycardia, when rhythm is regular but rate is less than 60 beats per minute. Sinus tachycardia, rhythm is regular and rate is more than 100 beats per minute. Monomorphic ventricular tachycardia, where white QRS complexes can be seen, and the rate is 140 to 200 beats per minute. Polymorphic ventricular tachycardia, where QRS complexes with constantly changing morphology and rate is 200 to 250 beats per minute. Regular rhythm means RR interval are the same across the tracing. Irregular rhythm means RR interval varies across the tracing. It could be regularly irregular, which is repeating pattern of varying RR interval, which we can see in atrial flutter. It can be irregularly irregular, meaning RR intervals varies erratically, which we can see in atrial fibrillation. Here are a few more examples of irregular rhythm. Ventricular fibrillation, which is chaotic, very rapid, irregular ventricular waves of varying morphology without clear QRS complexes. Heart block, when the electrical signals are delayed or blocked as they move through the heart conduction system, leading to irregular rhythm. Here we have second degree atrioventricular block, type 1 MOPUS 1, where we can see increasing PR interval leading to irregular rhythm. Second degree atrioventricular block type 2 MOPUS 2, where we can see PR interval is constant but failure of conduction of P waves leading to irregular rhythm. In third degree atrioventricular block, there are variable PR intervals, wide or narrow QRS complexes. There is no correlation between P wave and QRS complexes. And this is because of the complete blockage at the level of atrioventricular node, which leads to irregular rhythm. The electrical axis of heart is the net direction in which the waves of depolarization travels. Normally, this begins at the sinoatrial node. From here, the wave of depolarization travels down to the apex of heart. Axis indicates the direction of mean vector, can be determined from any waveform P, QRS, or T waves. The standard ECG reported QRS axis usually refers to the mean axis of frontal plane. It indicates the mean direction of ventricular depolarization forces. Normal axis is between -30 to 90 degree, and QRS complex is positive in lead 1 and lead 2 both. Right axis deviation, the axis is more than 90 degree and QRS complex is positive in lead 2 but not in lead 1. In left axis deviation, the axis is less than -30 degree and QRS complex is positive in lead 1 and negative in lead 2. The causes for right axis deviation may include right ventricular hypertrophy, chronic lung disease, or other conditions affecting the right side of the heart, whereas the causes for left axis deviation may include left ventricular hypertrophy or bundle branch block. This is ECG representation of left bundle branch and right bundle branch block. We can usually appreciate bundle branch block in lead V1 and V6. When we are seeing left bundle branch block, we are looking at lead V1 and we can see there is a deep and broad S wave. R wave is missing or smaller than normal, whereas lead V6 is positive with QRS complex with a notch R wave showing M pattern. In right bundle branch block, lead V1, the QRS complex appears as letter M. More specifically, the QRS complex display RSR pattern, whereas in lead V6 there is a broad S wave. Right bundle branch block is a cardiac conduction disorder where the electrical impulse takes longer to travel through the right bundle branch of heart's conduction system. This delay results in characteristic widening of QRS complex on the ECG. It can be caused by aging, coronary artery disease, structural heart defects, myocardial infarction, pulmonary embolism, hypertension, congenital heart defects, and pulmonary hypertension. Left bundle branch block is is a cardiac conduction disorder characterized by delayed electrical conduction through the left bundle branch of the heart's conduction system, and it can be caused by coronary artery disease, hypertension, structural heart defects, aging, myocardial infarction, cardiac surgery, idiopathic reasons, sometimes infiltrative diseases, and inflammation. Pathologic Q wave on an ECG indicate a previous myocardial infarction. It is deep white wave suggesting irreversible damage to the heart muscle. Q wave typically appear in a specific lead corresponding to the location of infarction and develop days to weeks after the acute event. The U wave on ECG is a small positive deflection following the T wave, usually seen in lead V2 to V4. While its exact origin is not fully understood, it is often considered benign. Changes in U wave can be associated with electrolyte imbalance, particularly low potassium levels. Here, this ECG can show a prominent U wave and prolonged QT interval, which indicates ECG changes due to low potassium levels. The interpretation of ECG should begin by evaluating the heart rate, rhythm, and axis, verifying the overall pacing and coordination of electrical signals. Subsequently, look for waveform segments and intervals to identify abnormalities or deviation from the normal pattern, ensuring a comprehensive evaluation of the cardiac function. Here is an example how to interpret ECG. This ECG is from Mr. X, a 60-year-old male. His heartbeat is at the rate of 70 beats per minute with a regular rhythm. There is no deviation in the axis. Importantly, the ST segment is elevated in lead 2, 3 and AVF, and I can also appreciate Q wave in the same leads, indicating a diagnosis consistent with an inferior wall myocardial infarction, which is probably secondary to the blockage of right coronary artery. Thanks for watching. Please do not forget to like and subscribe.